My name is Neil Creighton. I'm a doctor in Winnipeg, Manitoba, and I do sports medicine. And during the COVID-19 pandemic, it's been tougher for patients to access both medical care and in-clinic physiotherapy care. And, I found that it's harder to communicate some of the important facts about people's conditions with them. So I've done a short video on lumbar spinal problems, and I have that on my YouTube channel. And I'm going to do one now on shoulder problems, rotator cuff disease. So I'm assuming that you're a patient of mine, that we've had a connection, and that I believe that you have rotator cuff disease that's responsible for your painful shoulder. And so this is a chance for you to go home and spend a bit more time digesting that, or maybe we've done a virtual visit and I've said that this is what I think is wrong with your shoulder. So kind of this idea of, okay, doc, let's go through this again. What's really causing all my shoulder pain? So shoulder problems are very common in overhead athletes, tennis players, volleyball players. They perform maneuvers that put a tremendous amount of load through the entire shoulder girdle. This person is mimicking a thing we call the O'Brien test to cause pressure on the labrum or cartilage of the shoulder. This person is doing something very close to what's called Hawkins impingement sign, putting a tremendous amount of load through the rotator cuff with this really aggressive overhead smash. Not only in sport do we see difficulties with shoulders, but we see it from industrial athletes, people who are doing tasks over and over again perhaps in an online situation on an assembly line here. The person over here, you can see, is performing, again, a perfect Hawkins impingement sign. This is putting a great deal of pressure on the rotator cuff, pinching the rotator cuff. This person has better ergonomics with the arm lowered below the height of the shoulder with less internal rotation. So it's interesting just to see this in this particular clinical example. This person just looks so sad. And this person is doing, again, this Hawkins impingement sign here through the shoulder with the arm in a forward flexed position up around 90 degrees, the shoulders protracted, a lot of ulnar deviation, flexion at the wrist, flexion at the elbow, causing a lot of pressure here through the rotator cuff itself. So through this talk, I'd like to go through the following things. I'd like to talk a bit about shoulder anatomy, a bit about shoulder biomechanics, go through this concept of tendinopathy, rotator cuff disease, and the idea of victim and culprit as it applies to the shoulder. People come in complaining of a sore shoulder. That's the victim. What are the culprits? What's driving that? And hopefully you'll have a better understanding of what you're doing in your world to drive that problem more significantly. So there's no real true shoulder joint. There's four articulations that make up the shoulder region. The first one we'll talk about here, the sternoclavicular joint between the collarbone and the sternum itself. Very, very few clinical conditions to cause trouble here. The clavicle comes out. Second joint of the shoulder called the acromioclavicular or the AC joint here. This joint can be separated in falls or in body checks in hockey and tackles in football. Then we have the larger kind of true ball and socket joint here called the glenohumeral joint. And we like this analogy that the humeral head is like a golf ball sitting on the tee of the glenoid. So it's a relatively unstable relationship. And so what happens anatomically to make that relationship more stable is that we have this labrum here, the glenoid labrum, which deepens this fairly flat surface into more like a saucer surface. These labral tears are quite common in people when they tear a shoulder ligament by dislocating their shoulder and then damaging the labrum. So glenoid here, head of the humerus here. And these are both covered with a beautiful articular cartilage that gets worn out when you have shoulder arthritis. I like this cartoon because it shows the track of the bicep tendon here. The long head of the bicep goes really right through this very commonly compressed zone called the subacromial space. Here's the acromion, and beneath this space, we have the very vulnerable bicep tendon going through this intertubercular groove here on the arm bone, the humerus. So again, there's dense ligaments that form the outer part of the shoulder. We can refer that to the capsule, the ball and socket glenohumeral joint. These ligaments are damaged when somebody dislocates their shoulder. These ligaments here are damaged when somebody separates the shoulder, going from the coracoid up to the clavicle, and then again from the clavicle to the acromion here. And this is a good so-called lateral type look at the scapula, the glenoid in the scapula with his lip of labrum going around to stabilize the ball in the socket. So over top of the ball in the socket, this is a great cartoon from the genius Frank Nitter, who drew a lot of anatomic diagrams of the shoulder. We're just going to use this briefly. So we see here the supraspinatus. You may have heard of that muscle a lot. It's on top of the scapula, and it comes and it keeps the ball in the socket. And the rotator cuff is like a blend of these, kind of towards the front, subscapularis, towards the back, the infraspinatus, and right on the top, the supraspinatus. And this little spot here commonly wears out, leading to what's called a rotator cuff tear. You can get a sense that this is kind of going forward from posterior to anterior, a real common problem based on the serious postural challenges humans have. So again, this is a cartoon showing what could be called the subacromial or subdeltoid bursa, the people call bursitis. It can be irritated in this area. Our posture wants to bring the humeral head anterior, and that creates stress on the infraspinatus, trying to keep the ball back in the socket, and irritates the long head of the bicep. This is why you get a lot of advice about trying to pull your shoulder blades back to stop this tendency towards the humeral head going anterior. Again, this cartoon shows that underneath the deltoid is this large bursa called the subacromial or subdeltoid bursa, probably 30 or 40 cc's in capacity. And these often become things that generate pain at night. Clinicians have injected the subacromial bursa successfully for many, many years. It's a commonly done clinical procedure. Again, just to show you here, this is the front part of your shoulder. There's the long head of the biceps, one of only two tendons that go into a joint itself. So we talked about three joints. Here's the fourth joint. They call it the scapulothoracic interface. So we're looking at you from the back. Here's your latissimus muscles, the trapezius muscles, rhomboid muscles. Their job is to keep the scapulae back. And these are very, very important muscles. When we do things that are ahead of us all the time, we drive cars, we cook, we operate mouses, and we do weight work to bring the scapulae forward, these muscles tend to become lengthened and weak. And then muscles on the other side, the front, the pectoralis major, the pectoralis minor, tend to become dominant and strong and shortened, a common pattern of muscle imbalance around the scapulothoracic joint. So we really often want to stretch these anterior muscles out and strengthen the posterior musculature. We'll talk about that later. And here's why we have to do this so much. Look at this guy. He looks like he's 90 years old. And so this kind of chin forward, kyphotic spine, everything's going forward. And same thing, the challenges of being a student, scapular protraction, thoracic kyphosis, chin forward postures, things we're fighting a lot. These really negatively affect the scapular position. Well, this person's just showing off. They're perfect, right? Note how the hips are higher than the knees, the spine is perfectly straight, the eyes are the same level as the keyboard, maybe could even be a little bit higher, arms are resting, scapula's in a good position. So this person has clearly got a forward pointing, protracted right scapula. The edge is kind of coming off, and so this is tipping towards the front of the patient, which almost is like trying to pour the sugar out of a sugar bowl, going anteriorly. So the humerus wants to dodge and go forward. And these poor infraspinatus here, which is kind of wasted in this guy, looks like it's gotten smaller, common in rotator cuff disease. This guy, unless he's dyeing his hair, he's probably young to have significant rotator cuff damage. Another culprit that drives shoulder problems is what's called multidirectional glenohumeral laxity, or loose shoulder joints. We can examine this in the clinic relatively easy just by pulling down on the humerus and showing what's called a sulcus sign. This confirms that the person or the patient has a loose shoulder girdle. And we can sometimes see this in gymnasts, swimmers, contortionist types. These are really common problems, and they're common in what's called hypermobility. One of the things I see in patients so commonly driving musculoskeletal pain syndromes is hypermobility. And there's a Baton score we can calculate to determine whether you have a hypermobility condition. And one of the common clinical conditions that might be associated with hypermobility, Ehlers-Danlos syndrome. We can do other maneuvers to see whether the ball moves too much forward in the socket, too much inferior, too much posterior. We call that load and shift testing. So this laxity around the ball and socket joint contributes to difficulties with the shoulder, particularly the rotator cuff. Front, forward, Posture contributes to problems with the rotator cuff. Scapular position contributes to problems with the rotator cuff. This is a position we do to provoke that anterior instability. If you've dislocated your shoulder, this likely would make you crazy. It's another reason I don't like the military press for patients, because this position drives the ball forward. We know that driving the ball forward is a problem associated with non-traumatic shoulder difficulties. So we don't like that in people who have loose shoulder girdles, particularly early thereafter. Athletic-looking young man, we can see the scapular protraction forward, the pole of the scapula, very easy to grab here. And what tends to happen is the balance affecting the ball here in the socket. Note that ball on a T, so scapular socket, ball of humerus. This uneven pull will want to take the humerus anterior. What do we encounter? The biceps tendon coming here, which would come right over that region. Other things that can cause problems around your shoulder girdle, your clinician will talk to you about the cervical spine. Do you have a Z joint problem? So we can see that the cervical small facet joints can lead to pain around the scapula, pain over the rotator cuff. And a cervical radiculopathy, a pinched nerve in the neck, well, C5-6 supplies the rotator cuff musculature. So if that nerve is irritated, then you could have problems with the region around the rotator cuff. So repetitive strain injuries. I kind of find this kind of funny. So the most common non-traumatic condition that affects the shoulder is called the rotator cuff disease. We used to use the term subacromial impingement, but the mechanical features here are not guaranteed, so we prefer this term rotator cuff disease. You see an obvious rotator cuff tear. By our previous cartoon, this would be involving the subscapularis a little bit and mostly the supraspinatus here. And note these unyielding kind of roof or ceiling of the structure. This is called the subacromial space, where a lot of this difficulty transpires. So you've probably come by the clinic and you're typically having this front ache. It may go all the way down to your bicep past the deltoid. You may or may not have had significant trauma. And you're often complaining about pain at night. Doc, I can't sleep on either side because this really bothers me. There can be noises around the shoulder when you move it. So impingement has several things in the area that are angry. So here's the articular cartilage of the humerus. There's the long head of our biceps, starting from the top of the glenoid cavity, frequently involved in this process. The rotator cuff tendons frequently involved in the process. Subacromial bursae involved in the process. AC joint involved in the process as the unyielding ceiling. The acromion, imagine if the acromion had a bone spur coming down, making this area smaller. All those things are involved, which is why your doc probably won't say, I know you have just tendinitis or bursitis or bicipital tendinitis. You have kind of all these things going on, so-called syndrome involved. These are the victims. I really believe that one of the main culprits in driving this bus are these so-called upper cross syndromes based on postural imbalances from the way we're built by virtue of muscle mass and the things we do. Eyes forward, neck forward, chin forward, everything starting to go. Thoracic kyphosis, increasing cervical lordosis, and then the muscles at the front, tight, short, on all the time, strong, and muscles at the back, weak, long. Okay, we can fix that with specific exercises. This idea of tendinopathy, we kind of discarded the term tendinitis because most things that are sore in the body are not based on simple inflammation. They're really based on degeneration of the collagen tissue in tendons. So we see this beautiful linear tendon here that was originally your supraspinatus, and it kind of gets damaged, repaired, damaged, repaired, and that damaged, repaired thing we call tendinopathy. So it's a process from normal tendon. It gets a little reactive. The tendon repair isn't so good. This back and forth. And it's not inflammatory cells that characterize all this. It's kind of fibroblast cells putting down new collagen. I really find a lot that the infraspinatus gets irritable, a so-called trigger point, painful to touch back here. You probably didn't like it in the clinic when I nailed that spot. It produces pain going down the arm very commonly. So that is all part of it. Again, patients are often desperate. Doc, you got to figure this out by doing an MRI. And I was practicing before there was MRIs. Yes, I'm that old. And sometimes you get a bit annoyed that you don't want to do an MRI. You think your clinical assessment is sufficient. Well, these type of studies help us with that simple MRIs show that people who have no symptoms in their shoulder may have a rotator cuff tear 34% of the time. People who are 60 years old, 60% of the time they have rotator cuff tears. They show beautiful images. The head, the humerus here, here's the rotator cuff, and you can see that's a tear in the rotator cuff over there. The arrow sign, we call that in medicine. So again, there's a cartoon showing a tear of the supraspinatus, again, which commonly comes underneath this prominent bone called the acromion. Common in old folks. 60% of 60-year-olds, 70% of 70-year-olds. Really no 20-year-olds. So it's a degenerative phenomenon. This paper really spoke to me that it showed that in people who have MRIs, what they find in the MRI is not associated with their symptoms. So a tear size or thickness was not associated with pain or function. Fatty infiltration, which happens when people have tears, muscle atrophy, tendon retraction, again, not associated with pain and disability. It didn't make sense. What was the best indicator of a person's disability wasn't their MRI. It was a test on how they were enjoying the rest of their life. Very, very interesting. Another common thing, the Popeye sign, the torn long head of the biceps. We've talked about this long head of the biceps in this area getting frequently pinched as the arm is elevated up. It gets pinched underneath these unyielding ceiling-based structures. And in about 10% of us, it eventually just pops. Surgeons now actually cut the bicep tendon here, bicipital tendinotomy, to make subacromial impingement syndrome better. And again, this subacromial bursa, frequently enlarged, inflamed, something that we can inject easily. So rotator cuff disease, there's a whole bunch of things contributing to it. There are many things that may be sore in the neighborhood. Typical treatments, again, we're hard on posture, ice, relative rest, exercise selection, so important. Meds aren't a big thing for us when we treat people with rotator cuff disease. Therapeutic exercise and corticosteroid injections commonly done. This paper is sobering, and it says out of 6 randomized controlled trials on about 231 patients looking at various rehabilitative plans, none could be endorsed. And basically telling people to stay active was about as good as all the things I'm going to tell you now. So it's sobering to me. I don't necessarily believe this study, but I have to take it on face value that we give specific exercise advice. We're kind of based on preference. And I'm going to tell you my preferences. So I'm going to tell you that we want things to solve this. I think this is good for headache, neck pain, thoracic pain, and rotator cuff disease. Fixing this. Well, good ergonomics in the workplace, one place. I love the Brugger position. Simple things people can do, sit on the edge of their seat, retract their scapula, open up their palms, palms forward as opposed to internally rotated. Very good exercise. Remember that trigger point I told you about? You can work that out with massage balls either against the wall or lying down. We call that an infraspinatus release. If you're lucky enough to be able to afford or have benefits to see a clinician, massage therapist, physiotherapist, athletic therapist, active release therapist, chiropractor, may be able to do better release techniques manually on that infraspinatus. Do it against the ball. That can also be good for rhomboids and thoracic spine here. Which exercises do you like? I love this guy. He's getting it done. So simple things like active scapular retraction all day long. This is strengthening the posterior muscles and opening up the anterior chest cage. Beautiful view here of the so-called mountain pose. This is called anatomic posture as well by biologists and anatomists. The yoga people call it the mountain pose. So this is a beautiful pose that gets us into an externally rotated, more neutral position of the arms, scapular retraction, stretching out the anterior musculature. It can be a little harder if you do it on the ground. Same position, but now you're fighting gravity. Now we're fighting the resistance bands, or I could be doing this with some cables in a gym. Scapular retraction. We emphasize external rotation strengthening because your external rotators are the size of McDonald's hamburger. They literally weigh less than a pound. But you've got 10 or 15 pounds of internal rotators, latissimus, pectoralis, teres major, big muscles internally rotate you. And you do it all day long. So we tend to emphasize external rotations with Theraband or other tissues. I love the scaption position. thumbs up 30 degrees ahead of the coronal plane, not going above the shoulder, activates the rotator cuff very well. So strengthens muscles to stabilize the shoulder without perturbing it or impinging it more. For folks who have loose shoulder girdles, stability exercises, this is called a closed chain exercise. On the Bosu ball, an unstable surface, I have to demand my neuromuscular system work very hard to stabilize my shoulder. So I really like the Bosu ball. The position here is also very, very good for fighting impingement loads. Doesn't hurt the shoulder too much at all. If I've dislocated my shoulder, here's a more therapeutic exercise, getting overhead now, working dynamically with the ball against a trampoline. So an overhead thrower would do this. A baba with a sore shoulder knitting would not do this. And then kind of finally, we do these subacromial injections with corticosteroid to decrease that night pain in particular. It's not the world's best evidence to justify doing this. It's a safe procedure. What's called level 5 evidence, the evidence of the clinician, is that I've seen lots of benefit with this. It's relatively cheap. It's quite effective, especially at night pain. And I can honestly tell you that I've seen almost no deleterious effects of this over 35 years. Evaluating exercises, questions to ask, whether you're doing this yourself during COVID or if you have a therapist or a personal trainer. Will my exercise put my shoulder into an impingement position? I want to avoid that. Will it make it unstable? Will it produce vulnerability for my rotator cuff tendon or my bicipital tendon? Is there a more sensible way to do this strength training? I see that's a very simple question that we always have to ask our patients. For example, this is called the Hawkins impingement sign. It's how I bug you by bringing you into the clinic. It's how I pinch your rotator cuff. Doing it over and over and over again doesn't seem to make much sense to me. It's been a pleasure speaking with you today. Avoid impingement positions. I hope you have some do's and don'ts about exercise rehab now. I want you to activate your scapular retractors all day long. Close chain if you got a loose shoulder joint. And bring in your lower extremity. Get on the Bosu ball yourself. Do them on one leg. Don't do them seated. Not a good thing, except for Brugger when you're at the office. Thank you for your attention and take good care. Bye-bye.